They're always late. It's pointless.
They're colluding in the hall.
Real collusion going on there.
Okay, we're live in Senate Appropriations.
Didn't Watson this time bring?
Yeah,
This
that's this time. FY 26 budget request today or right now. District Mountain Care Board, thanks for coming in for your budget. I'll let you introduce yourself for the record and proceed with your presentation.
Sure, I'm Jean Stutter, I'm the Administrative Services Director for the Green Mountain Care Board.
And I'm Owen Foster, I'm the chair of the Green Mountain Care Board. And also with us today are Diane Medford, our Director of Legislative Affairs, and our Executive Director, Susan Barrett.
Thank you, you're welcome.
Thank you. Thank you for having us. I'll give a very, very brief overview for those of you who I haven't met of what the Green Mountain Care Board does. I won't take up much time. I'll turn it to Ms. Stetter for the nuts and bolts of the budget. Green Mountain Care Board, high level, we regulate hospital budgets. We regulate the qualified health plans that two insurers offer on this market, and we regulate ACOs. We also have a division of work related to, accountable care organizations. So that is One Care Vermont, and then there are a number of what we call Medicare only accountable care organizations. Those don't have commercial or Medicaid, they're just Medicare only. One Care Vermont is closing its doors at the end of this year. We're seeing more Medicare only ACOs come into the market. We also have a data team that does data analysis and analytics that provide and power a lot of the reports that the Care Board provides to the legislature. We also have a prescription drug advisory board with a staff of, I believe it's 27 currently, and 5 board members. The 5 board members are all appointed by the governor after a nominating process with staggered 6-year terms. And I think that's probably a sufficient overview unless there's questions on the generalities of what we do. I'm prepared to speak more granularly to the healthcare system in Vermont, some of our particular work, if the chair and the committee would like. Otherwise, I'll just turn it directly to Ms. Stetter for the budget.
Thank you, Chair Foster. And the reason he's doing that is when we were in House Approach, there were so many questions about the healthcare landscape in Vermont that we had about 30 seconds for the budget.
Yeah.
So I thought he thought we'd just start here. So, so again, as Chair Foster said, we currently have 33 positions, 5 board members are exempt, are primarily our lawyers, and then classified positions.
So where's this screen? I just want to make sure I'm following along.
Oh, sure, page 15
Okay.
on your presentation. And again, I apologize for, I'll wait until you guys all get there.
No, that's fine.
Again, we were just trying to make sure we have plenty of time for the budget.
We appreciate it.
So, so I'll just talk about the changes from last year. So historically, basically the funding split for the Green Mountain Care Board has been, for the biggest statute that we have, it's about 40% general fund, 60% special fund. That special fund is the Green Mountain Care Board Build-Back Fund. So what that means is we charge the entities we regulate for the pleasure of being regulated by us. What's new last year is Act 134 was passed by the legislature. That's prescription drug regulation. We have 2 employees working on that now. And that is 100% funded by the special fund. It's the evidence-based advertising fund. So that's kind of the shift in our funding. If you look at, you know, what you're going to be looking at is, you know, our increases in line with what you'd expected. So, so overall for the Green Mountain Care Board, and not including the governor's like base initiative, and I'm just going to pause here and say the documents that are posted on your website also include an acronym list. We know that it's, and please reach out if there's any acronyms that are not answered. So long and short of it is we are up, we met the governor's recommended increase of 5%. As you can see here,
did he give you a different recommendation from everybody?
Well, so we were up 3%, and then they gave us additional, general fund for internal service funds
Okay,
and, benefits, so
that's where you get to the 5%.
yeah, that's where we get to the 5%. And as you'll see from every other agency or department in the state, our salary and fringe is up more, which meant, we had to reduce, contracts in order to meet that budget. The 14.9% is the Act 134 money. Because that's a new initiative, it's not technically counted in the big bill, so I just wanted to call that out separately. We did request from the governor's office new positions for the new federal healthcare reform model ahead. We requested 5 and we received 3 full positions and money for contracts. So the $750,000 is gross. It includes the $300,000 that we got general fund from the administration plus the build back funds that we have. So that's how we show being up. Now within, no surprise to you, there's a lot of opportunities and unknowns in our budget. The first is if the AHEAD model is to go forward, the way that the Green Mountain Care Board was able to sign on as a signator of the AHEAD healthcare model is we need 5 positions in order to be able to, it's a material amount of work, so we need 5 positions. We have 3 here, so we need 2 more for FY26 permanent positions. And please look here that there's more positions needed
15.
in the future. Yeah, plus limited service positions. So
There's not more money from the bill back or anything because of the AHEAD model.
any additional general fund, the way our statute works is any additional general fund we get, that can be 40% and it can be met with the bill back. The important thing to notice there is who's paying.
Right.
It's the hospitals and the insurers. And we know what the hospital is doing and we know about Blue Crosses. So it's not something we take lightly.
And who signed on to AHEAD? It was the governor, the care board, and third person, right?
Secretary of AHS.
Yeah, I'll just back up a little bit background on the AHEAD model. So the state had the all-payer model that terminates this year. The 3 signatories, AHS, the care board, and the governor, signed in January to start the AHEAD model in 2027, which is a payment reform to pay based on global budgets. Some of the giant unknowns out there, and there are many, is whether or not it will ultimately be favorable from a financial standpoint to the state of Vermont. That is very difficult to calculate and predict. Second, we signed it with the Biden administration. There's now a Trump administration. They have material differences in their policy directives. So where they are is unknown at this time. We've had a blackout where they're not permitted to speak with us in this period, so we don't know where they're at. And then third, as of now, it's a voluntary model, which means hospitals would have to want to sign up. And if they don't sign up, we're not doing it. So there's all those pieces out there that make it a lot of unknown. The work in changing from a fee-for-service model to an entire new payment mechanism is a significant work.
Isn't that what the One Care was trying to do too?
Somewhat, a little bit differently. It was still a fee-for-service backbone to it. It involved, not all, but most of it was reconciled. This would be moving away from that reconciliation to a true global budget. Anytime you change the payments, there's all kinds of things that pop up that you don't anticipate, you have to watch for, or it destroys the model. For example, will it blow out, meaning there'll be more money spent on professional services that are not in the global budget? Will money be moved to other services that are not captured? Because it's natural for an organization to try and find other paths to make money. You have to watch for those and make sure the model's working how you hope. So there's the work to come up with a methodology, the work to come up with a regulatory structure, work to then come up with, actually execute on all that, monitor all that, and do all that.
And all three signatories knew about the need for this 16, 17, 18 new positions.
100%. And just so everyone knows, when the board voted, it was difficult to get to 3 votes. We had to get 3 votes to pass it. We were able to do so, which I'm thankful for, but there were certain conditions we needed to get to think that it would be a positive ultimately. And one of them was resources to do the work.
Right. Which of these, what we're talking about here?
Exactly. If the model does not go forward, I don't know if the Trump people will cancel it, whatever it might be, we would not be requesting these positions for that work.
Okay. Right.
Thank you. So switching away from ahead here, the next line, this is one pitch we had that the governor did not support is our data and analytics team were stewards for the healthcare claims database and the healthcare discharge database. And there's a lot of reporting we do, and our wish would be for 2 12-month limited service positions. They'd be $100,000 each, all in, and we could hire them to allow automation to happen in reports. So basically what that would allow is, as you can imagine, kind of virtually all our work, there's a lot of demands on our data and analytics team. So that would just allow us to get out from under some manual work and, free up more time. That's our vision. The third thing that I want to talk about is, this is our billback language, and then also S63. This is a pitch for S63. So as we referred to recently, the state's big accountable care organization called One Care Vermont has announced they're ending business December 2025. In 2018, there was a change to our bill back where that was forced by a number of entities and a stakeholder group, and that stakeholder group at the time agreed that the 60% that we bill back would be shared by hospitals, insurers, and we added the accountable care organization. And that's when the landscape was when there was One Care Vermont, one big accountable care organization. Now, essentially because the accountable care organizations, the hospitals paid fees to them, the hospitals were kind of paying for a lot of that. But now that One Care Vermont is exiting the market, we need to shift our bill back to bring the flexibility needed for the ACO changes. So the draft language that we have, and there's a paper copy floating around the room, what it basically says is it lists out the percentages.
So did you submit that for the website?
Yeah, I submitted for the website, and Elle
Oh,
has
it's under your.
manual
Yep, I've got that.
paper copies too. You should have a paper copy available to you if you want for ease of reference.
I don't see it there, but maybe
I'll make sure.
Okay. Do you have, I want to make sure you have what you need before I keep.
I just want to make sure
I'll
it
make
gets
sure.
on the website. Go ahead.
Okay. So that was changed in 2018 to reflect how the entities we regulate would be billed as the state of the healthcare regulation we were doing at the time. Since One Care Vermont is exiting the market, we need to change our statute And what that will look like, and I've worked with both the insurers and BOS, the Hospital Association, is that the majority of the increased cost, majority of the cost will be shifted to hospitals. And then the insurers will take about 5% of the cost. And the logic behind weighting it more heavily towards the hospitals is they were previously paying dues to One Care Vermont, and this amount will be less than the dues that they're paying to One Care.
So I was gonna say, with One Care going away, I would assume we're saving money because they were spending so much money. I would hope that there's some savings, or does that just all kind of go into the head model somewhere else?
Well,
So relating to our budget, I think what we're saying is ultimately it was indirectly paid for by the hospitals. Hospitals paid the dues, then we regulated, then we billed back, and they paid us. Ultimately, that was effectively the hospital's money in the first place.
Okay.
So this is disproportionately weighted towards the hospitals as opposed to the insurers because the hospitals are paying it all.
So there's not really a savings, the money's just being shifted around.
For purposes of our bill back.
yeah,
In terms of the One Care savings, the broader, so One Care's budget historically has been $12 to $15 million a year. That will be a large savings to hospitals. They're not paying the dues to finance One Care's operations. So that will be a large savings.
Good.
there's another important piece to this, which Chair Foster spoke to earlier, which is the Medicare-only ACOs. So, and that's where we really, the Green Mountain Care Board really needs S63. And specifically, our ACO, Accountable Care Organization, regulatory environment was created when we had One Care Vermont. Now that there are Medicare-only ACOs in the state, and we think that they could increase because they could solve a gap for the FQHCs and independent providers, and the gap between One Care Vermont and the Fed model coming in. We would like to, S63 has review and fees that are specific towards the Medicare-only ACOs, so it reduces the cost and it reduces administrative burden, and makes it more appropriate for a smaller ACO. So to make it more favorable to come into Vermont, and they typically have fewer members, and so we would like we support S63 in that way because it will reduce the regulation, it will adjust the fees, and it will reduce the administrative burden. Specifically, the Medicare-only ACOs, the federally qualified health centers and the independent providers, with the end of One Care Vermont, One Care Vermont gave them, being part of One Care Vermont and in the ACO, it gave them, kind of a predictable payment stream, and they didn't have to do federal MIPS reporting. I don't know what the acronym means. I can get it back to you, but basically it's federal reporting. So if those providers join with the Medicare-only ACO, that could provide some of the benefits that One Care Vermont did. We don't have the landscape to know what people are going to do and how it's going to happen, but anyway, that's questions about that before I move on to the next thing. The big unknowns, I'm just going to speak to briefly, and then I'm going to hand it over to Chair Foster. You know what, actually, I'm going to pause here. Do you have any questions on our budget? Because the balance of yes.
I don't have a question on your budget, but I'm looking at your mission, and maybe I missed it during the intro. Could you just list maybe a brief success of your top two Performance measures here, that's what you've been doing?
Sure. So I've been at the board, I think, 2.5 years now, so I'm most familiar with that period of time. I think the biggest successes we had is trying to control the rate of, so let me back up. When a hospital comes to the Green Mountain Care Board, they ask for two things essentially: increased payment rate from commercial insurers and a larger total revenue. Rate is how much money somebody pays for a particular service. So if it's today $100, and they ask for a 10% increase, it's now going to cost $110, right? So in the last 7 years, we've seen really gigantic rate increases at our hospital system across all hospitals. We tamped that down pretty significantly in the last 2 years, and more in the 3 to 4% range, which is consistent with medical inflation. That's had a big benefit in that when that goes up, what everyone pays in the state for commercial insurance goes up. So tamping that down has had a benefit of over $100 million in savings to commercially insured Vermonters. The other component to that is there has been a pretty steep inequity between hospital providers and non-hospital providers in how much rate increase they get from insurers. What I mean by that is if you look at primary care, independent primary care, FQHCs, independent practices, whatever it may be, those are often your most affordable, your most accessible and high quality providers. If you lose those, you lose access to really important preventative care. Take, for example, Lamoille, the FQHC in Lamoille. If they go out of business because they're not getting sufficient rate to pay their bills, you have a problem of primary care access. And one of their problems has been, one, a really steep increase in their healthcare costs, and two, their commercial rate increase is not going up much. So by tamping down the rate that hospitals have to be more consistent with everyone else, we've sustained or helped improve sustainability of the rest of the healthcare system. So I'd say that's one giant one. Another one I would say is on the ACO regulation, we've removed several millions of dollars from the Accountable Care Organization's budget and redirected that money to care for patients. So we capped their salaries, we capped their their administrative budget, and then we directed them to use that money to support primary care, mental health, and other providers that need the money to sustain themselves. We've seen no deterioration in the ACO's performance because of those decisions, and that money's been used by providers. I think those are two of the ones that stick out to me in recent years.
And just a quick note, have we lost any QHCs at all in Vermont?
FQHCs?
FQHC, I'm sorry.
No, there are a number in deep financial trouble. And there's been a number of services reduced because of financial troubles at FQHCs.
Thank you.
Would you want to do
But
the,
that's not,
Go ahead.
it's not just the FQECs are in trouble. How many hospitals are, have budgets in deficit?
I don't have the exact numbers in my head, but many. So,
here, this has the date, I'm not sure where you want to go, but.
sure, yeah.
Do you want to pick up here or somewhere else? Sorry,
That's
I don't
fine.
need to.
No, thank you. The primary measures we look at for financial health of hospitals is days cash on hand and operating margin. And to Senator Weston's point, the hospital system, the days cash on hand has deteriorated significantly since 2020, actually really since 2017. We see it was around 190 days, now it's down to about 125 days. And within the hospital system, some are doing better than others. So if you look at Copley, if you look at Springfield, if you look at Gifford, if you look at Grace Cottage, Eastern, their operating margins and their days cash on hand are very low, and that's the trend they're going on. They're going in the wrong direction. And there's really nothing that we see on the horizon that will abate that. And we have seen hospital line changes, other than Senator Lyons' bill.
Good thing.
I pulled up the foundation.
So, how familiar you are with all of our work, each of you, but when we give more money to hospitals, it comes from somewhere, and it usually comes from commercial insurance. And Vermont has some of the highest commercial insurance costs in the United States of America, if not the highest. And our rate of increase is the highest in the country, and that's not abating. So I think last year Blue Cross received between 18 to 24% rate increase. This year, I'd be shocked if they don't come in at 15% for a request. Year before that was around 15%. What this does is it drives up property taxes, drives up business costs, decreases people's ability to afford healthcare. It hurts our demographics, hurts younger families, hurts our most vulnerable, hurts our poor. So that's what we try to ask. What do we do? We try to balance that. We try to make sure we don't have an insurer go insolvent. We try to make sure the systems of care are here for people and we have access. Just real quick, Blue Cross, I don't know how familiar you are with Blue Cross's situation. It's been in the media. Their line down is worse than that line down. They're in acute financial distress.
I hate to ask this question, but you have to. 20 years ago, we were in the bottom third in the country in the cost for education for healthcare, and now we're practically at the top of the country. What have we done wrong?
That's a great question. So it's an extremely complicated question, and I couldn't properly answer. It's a thesis, right? It's a college course. My view is we have not done a good job of allocating our resources where we want them to be allocated. We have not adequately supported the preventative care services we need. We've not adequately supported mental health, primary care, long-term care in this state. So I think that's one big piece of it. Two, this might not be a popular answer, but I think we have a lot of things around healthcare that are very expensive. I think if you look at the outcome of One Care, I'm not blaming One Care, but it didn't work. It didn't work in a way that hurt our financial affordability. It was expensive and it didn't work. It's not their fault, it just didn't work how we wanted it. So I think having so many systems around the healthcare system that aren't actually providing care, and I'll include the Green Mountain Care Board in that, it's expensive. We're expensive. Here's our budget, it's expensive. Our job is to make it effective, just like it was One Care's job, just like it's UVM's network's job, just like everything else. So I think one is our system of care has been very much concentrated on hospitals, and that is a very ineffective and expensive place to do it. Hospitals do a lot of things amazingly well, but we need them to be hospitals. We don't need them to be everything else, because when they're everything else, it gets really expensive. There's some level in a rural state where you're going to need them to be everything else, depending on the community and the geography. So if I'm thinking about St. John's Berry or Newport, there might be more reason that they need to be everything else. But as a state, we need to make sure we have those systems around the hospitals.
How much of that increase of Vermont average from the national average, where somebody pointed out to me that Vermont being the highest in the country makes us the highest in the world because the US is the highest cost country in the world. But of that answer that you just gave Senator Weston's question, is there another part that's just demographics of just like an aging population and more acuity as they get older, and or is that a small percentage of it?
Yeah, I don't have a percentage amounts. I would say I don't love that rationale. And the reason I don't love that rationale is
because that's what you hear a lot of.
Yeah, well, yeah, I know. And that's why I don't love it. So here's my reason why I don't love that rationale. There's some degree of that in there, some, sure. But older people are paid for by Medicare, not commercial. So to presume that the aging and the acuity is what's driving our commercial has that fundamental flaw in it. What that would presume is that also that Medicare doesn't pay adequately. And for hospitals anyway, across the country, you see many hospitals able to survive on a Medicare break even or pretty dang close, okay? So part of our problem is our Medicare cost coverage. 10 years ago, I don't want to pick any hospitals, but there's a hospital large that was over 95% Medicare cost coverage. That means to see a Medicare patient, Medicare paid at least 95% of those expenses. That number today is more like 70%. So as you deteriorate on your ability to run on Medicare, as your expenses bloat at your hospital, this does become a problem with aging because you can't break even on Medicare. So what we're trying to do in our regulatory process by tamping down that commercial and in our communications and everything we're doing is you got to run on Medicare. The other system problem is as our demographics get worse, there's fewer people on commercial insurance. And if people are making up for inadequate coverage by Medicare or Medicaid, there's fewer people to take it. And that's when that number goes crazy. And our projections for demographics is worse, not better. So it just won't work. It will not work.
Do you have a follow-up question?
I had one follow-up. It's a comment and a question, but I never hear you talk about, you know, in every organization that I've been affiliated with, in 16 years on the hospital board. I'm on the FQHC board that you talk about. I've been on my nursing home board. Every organization I'm talking about, the underlying problem really is staffing. And it's traveling nurses and that. And we're bailing nursing homes out right and left. At some level, we haphazardly go after that issue. And it's hard here to compete with a Boston to get professionals here. And I never hear you talk about that.
I talk about it all the time.
Yeah, but the places I am, you don't. And you just didn't mention it here.
So I'll talk about it. I talk about it all the time. Staffing's a challenge in the state. And it's a challenge for all providers, for hospitals, for FQHCs, for everybody. And it's a different problem for different places. SVMC, Rutland, they've done extremely well with traveler expenses. Some places have bigger problems with travelers than others. Some have almost no problems with travelers. That problem's abating fairly dramatically. If you look at some of the UVM numbers, they're doing much, much better on travelers. But no, it's definitely been a problem. I don't know what we do about that problem. Does that mean that we increase commercial costs to the point that they're not affordable? Do we hold hospitals accountable for how they're doing on travelers? I think we have to.
Some hospitals have done better at, Southwest has been, much better at figuring out how to educate nurses and get them there. And, you know, other places haven't. Maybe there's something to be learned about that and pushing hospitals and organizations into a place where we're more proactive.
Agreed. Yeah, in Southwest, I couldn't speak for all the great things that they did do, but they have actually, early on, they cited this problem. And this has come out, we talk about in every single hearing we have. They came out and they had a program, they recognized the storm clouds, and they said, we're gonna do retention bonuses, we're gonna raise people up, we're gonna give them promotions, and they did an incredible job of keeping their staff. Others have been grow your own, where people have an opportunity, a pathway to get the education to become nurses.
They also partnered with the higher ed community to produce nurses.
Correct.
And in 2016, they were working on housing for their nurses, which would have the double benefit of revitalizing their city, you know, taking blighted properties and improving them and also provide housing. So,
Senator Norris, did you have a question?
I did. Don't anybody take these personally, okay? My concern is being one of the new members on the board is checks and balances. So how do we, or who measures the success of the Green Mountain Care Board?
I think it's probably threefold. It's probably the legislature. Your budget, you decide if we should have the money, if we're using it well. I think it's probably the governor, and I think it's also the public, frankly. I think those are probably the three constituents that should look at it.
And the reason I ask, because of the increased positions that we may be looking at in the coming years here, and you know, how beneficial is the Green Mountain Care Board? And I'm not saying it's not what I'm saying.
No, I think it's an absolutely, we have to ask that question of everybody right now. Like, the state is in such a dire place, you have to. So I think the answer is, if you're looking at so one of our biggest challenges in the state, that for an affordability standpoint for healthcare, are our hospital prices. There's a number of things you can't control in healthcare. We can't control the demographics. Care board's not going to do that. We can't control housing. And we can't really have almost any influence on whether or not nurses or doctors come here. There's some things we do, such as supporting the ones we want, like primary care money, we talked about those kinds of things. But one of the biggest challenges we have, pharmaceuticals, that's a difficult nut to crack. No one in the country has cracked regulating pharmaceutical prices. People have tried, we're making inroads on it, we're working towards it, but that's litigation to the Supreme Court for years. Utilization is really hard to tell people you can't go to the doctor. So you need to encourage people to move out of the hospitals. I'll use an example. So UVM's budget this last year, We didn't give them exactly what they asked for. And we said, part of this is you need to move patients out of your ED to primary care, to mental health. We have a giant network and a population health services organization of 100+ people. They need to work on moving these patients out. That will improve affordability and patient care. The other large problem we have in the state, some of our larger hospitals have extremely high commercial prices. When you have utilization uptick at really, really high prices, you have a bankrupt insurer. You have people who can't afford healthcare. In the last couple of years, we've really been tamping down the prices while trying to keep hospitals afloat at the same time. That's a difficult balancing act to do, but that's why we've gone to a more medical inflationary based rate increase. So I think that is one of our biggest problems, and Senator Lyons has a bill with reference-based pricing in it this year. The goal of that is to tamp down those prices because our hospitals have prices that are too high for us to afford. So I think that's probably where we're going to be making most of our inroads is on the prices. It should have the collateral impact of reducing administrative waste within the system and improving access, as people need to see more patients to make the same recommend.
Thank you. Folks will notice that. Decreased prices.
It's really hard, and there's a balance though, right? So success is hard to measure because I could argue if you don't give money, you're going to lose services at a hospital or even lose hospitals. So that would be a negative on the scorecard for the Green Mountain Care Board. However, if you increase prices and it does this, that's also a negative on the ledger for us. So there is a balance to all this. It's difficult.
On the positions, you're not asking for FY26 for any positions above the governor's recommend. You're just giving us a heads up that you might need them if we do the head model. Am I right?
So two things. So the ahead model, the way the board voted, there are a set of conditions that the board was comfortable with supporting the ahead model with. And one of them was 5 positions within fiscal year 26. Sorry, fiscal year 25 by September 30th of 25. We don't have the positions to come up with a methodology and the regulatory environment. The care board, I am required by the vote to exit the model.
But those positions were in the governor's recommend.
No, the governor's recommend had 3 positions, not 5. So it's too short of the number to not exit the model.
Okay. But even then, when would we know about all the other positions? When do you think? Next fiscal 27 kind of budget?
Sorry, ask.
For FY27, is that when you would know whether you would need the 20 positions?
We'll probably know quite a bit
Or the
sooner
15
than that.
positions?
Yeah, earlier. So hopefully the new federal administration will give us some feedback on where they're at pretty soon, we'd hope. And then I think everyone's still continuing to work to determine how everyone should prioritize their work in healthcare. Healthcare is one of the biggest problems in the state right now. There's no question about it. So it's a question of priority and what are we working towards? What tools are we using?
Yes, Senator Lyon.
I don't need to say anything, but I do need to say something, and that is investing in work going forward can save us a lot of money. So hearing about the need for positions, whether it's to put in place reference-based pricing or global budgets or whatever, it will save a lot of dollars. Investing, taking money and paying off property taxes or providing for 1 year of stabilization for a healthcare facility does much less. I don't know it's how you balance the needs and where you invest.
And all those, thank you, that's important to remember. But the other personal services, is that what the 5 positions are? Is that $750,000? So why are they there and not like in salary?
Because that's the way, Department of Finance and Management wanted them represented, because the only salary benefits is everything that's been approved and blessed. So because of the people
It says it's
and the
an
legislature,
extra
yeah,
something. Okay.
Yeah.
I get it.
yeah. So I worked with our, Emma Fedor, our budget analyst, and worked with those.
It's probably
Go ahead.
worthwhile mentioning too, just for a sense of the size of our organization, right? So when you're asking for more, it's a hard ask in this environment. What we've never made that ask since I've been here. We're asking because there's additional work that we want to do for the benefit of the outcomes from that work that we all anticipate. But to give you a sense, to compare the Care Board to other regulatory agencies in other states, we're a fraction of the size of similar organizations that actually have less work than we do. They have less scope of regulatory responsibility. PSD and PUC here in Vermont, much larger regulatory bodies in the energy space than the Care Board in the healthcare space. I believe, yeah, so here, the Maryland Service Cost Review Commission, a similar organization, staff size of 60, we're staff size around 30. Mass Health Policy Commission, staff size 174. We're around 30. And we do different things, like these are not apples to apples, but it's a sense of scale that I'm trying to give you. And I think that we actually do quite a bit more in terms of our responsibilities in these organizations. They're bigger states, but there's not really economies of scale necessarily. PUC and PSD, I think total over 80 positions at the PUC and PSD, and the Care Board total about 37. So just a sense of scale and scope of various other regulatory bodies in healthcare or here in Vermont, we're trying to give you a sense.
So that's the broadband board, I assume, from PUC, PSD. I don't know if you included the broadband.
Oh, no, I excluded the broadband board, yeah, just, they're listed separately as
Yeah,
a
they're-
subset, so it was easier to kind of.
No,
break it
and
out.
it's more accurate. Probably.
Break it out that way. There's, whenever appropriate, I have
I
two
don't know what
things.
that, where the music.
I have two things to,
GovOps, they're pretty good at that.
yeah, exactly.
Out of control.
I have two things to follow up on whenever appropriate.
Well, I had a question on a slide 19, or it's page 19. I don't know if that's slide 19. Yeah, one that one. So
Mhm.
without having me to go to the acronym chart, what are these line? Is this general fund, state fund, global commitment? Like, what are these?
Yes, thank you. And I appreciate you calling out my acronym soup. The green line is general fund. I usually do this green,
Yeah.
big Vermont, state funds.
Yeah.
The purple is special fund, so that is our build back fund.
Right. Makes sense.
When there was a time where the board did have some federal funds, and then the yellow line is global commitment. We were an investment named in the 1115 global commitment waiver, but as you can see, that went to zero. So
Because it was like funded as an investment at the beginning.
it was funded as an investment, and due to the cap and AHS's valuation of resources and need, we dropped off. We were still listed. We were still listed in the agreement, but they, because of the cap, they needed to shift us to zero.
Okay. What was your other?
I have two other things. One downside of having me go first is one thing that those who are new to Green Mountain Care Board may not know is that we are a fully transparent organization. All meetings are public, all decisions are public, hearings are public. So when Chair Foster was speaking earlier to public input, like there is lots of opportunity for public input. So I just wanted to stress that. That's something unique about this. The hospital budgets were previously done by Fishka, which included CFR, and you know, it was all behind closed doors. So we're a public transparent process. This is a little bit of inside baseball, but it could become important. So with the ahead model, we requested 20 full-time permanent positions. There's no contract dollars associated with that work.
Did you request them?
20 20 over the period, I'm sorry.
Or just like an estimate, if you go ahead with the model, this is an estimate of what we need.
Correct.
But you haven't really asked
So
for
this year, we've asked for 5, and that will let us do the work we did this year, and then if the model goes forward, we would come back next year, so it's staggered.
15 more.
Right.
So, yeah,
Sorry,
thank you.
Jen.
No, that's okay. My point wasn't so much about the number of positions in that there is 0 contract dollars because we have this cooperative agreement from the federal government signed by Biden, blackout now. But there's millions of dollars of contract funds that we are planning on, if this work goes forward. So if we, if there's potential, if we were to, lose the ahead model and still want to move work forward, we would need both positions and contract to fill up the gap, but that's just,
For now, we have funding as part of the model agreement
yes.
for the feds to give us at least $12 million in funding for contractor resources needed to do this work.
And you think you'll get it? Is there a chance that that money would come?
We
It's a small-
think it should come.
Right. Legally, we would get it. If
We
laws.
have signed agreements saying that we should be getting that money.
Right.
What we do have is an agreement that anything we spend should not be clawed back.
So if we spend it now and it terminates later, we don't have to pay back this
Right.
funding for the work that we've done together. It was a really important.
Hopefully the judges agree.
Yeah,
Hopefully we don't go there.
yeah, hopefully that's not,
Okay, well, otherwise, it seems like the budget's pretty straightforward.
Yes, we think aside from the ahead model work, it's a pretty standard budget that we've given pretty much every year.
Any other questions for the care board? Medical questions on that?
yeah. Okay, the last thing is,
Right, you guys.
we're delighted. We were right by, Bailey and State, so we were flooded. 1-story building, no basement. We were flooded and we are just moving into our new space. National Life gave us,
Oh, so you're gonna be up in National.
no, we
Oh, no,
were, we
you're
had like
here.
6 cubes, so yeah,
Right
so
above the
we're,
PUC.
What about you?
we're right by the PUC.
Yeah.
So we're delighted to finally, like,
Have an office.
copier, we have a copier.
Coffee, coffee machine.
No,
No.
haven't had the coffee machine yet, but
Not
we're
yet.
working on it. So,
Sounds like a really short field trip for my community, right?
yeah.
Love that.
Okay. Oh, yeah, so a separate question I'll ask the committee. So if there's nothing left on the Green Mountain Care Board,